Hello, everyone on the emergency department team. This is Jeannie Burney, and we're back with another podcast. And I'll do my ADET. I'm Jeannie Burney, for those of you who don't know me, and I am the clinical nurse specialist for the emergency department service line. And I'm so happy to be here today with Kim Ritter. Kim is a staff nurse at Good Sam, and I'll let her do her ADET as well. But I want to just let you guys know that we're going to be talking about managing patients with alcohol use disorders in the emergency department. And the precipitus for this project is that we have a new CWA order set that our ED physicians and advanced practice providers will be using. So we wanted to just do a quick review. So I'm going to turn it over to Kim so she can let you know a little bit more about herself, and then we'll get started.
Hi, I'm Kim Ritter. I am a staff nurse in Good Sam's emergency department for about 10 years. I work night shift. I've worked night shift pretty much since I've been a new grad.
Good enough.
Yeah, good enough? Okay.
Yeah, I think it's good enough. We just want to make sure everybody knows who's talking. And she definitely has some expertise in this topic, working in the emergency department for several years. It doesn't take long. So let's take a look at alcohol use disorder and why we might see these patients in the emergency department.
So there are over 8 million individuals in the United States that are dependent on alcohol. It's more men. 20% of men, 10% of women suffer from alcohol use disorder. And extreme complications like seizures and delirium tremens can be seen in 3 to 5% of those patients. And over 1 million individuals are hospitalized every year with alcohol use disorder.
Yeah, the interesting thing about that is it feels like, I think we see a lot of people who come in with alcohol on board. Now, whether or not they are officially determined that they have an alcohol use disorder may be not evaluated until a little bit further down the line. But I just like to throw a little bit of kind of background information in there so that we know that this is definitely a population of patients that we will be seeing in the emergency department. So let's talk a little bit about why alcohol becomes a problem for people.
So alcohol is a CNS depressant. It potentiates the GABA receptors, which enhances central inhibitory tone. These NMDA receptors are changed when somebody is a chronic alcoholic. So the person develops a tolerance, essentially. And when the person with the alcohol use disorder stops drinking, these receptors are so used to being depressed, it leads to an excitatory effect. So they're hyper-stimulated, which can mean seizures and delirium tremens.
And that's always what we're worried about. I've been a nurse for 35 years, and, whenever you think about patients who are alcoholics in the emergency department, that's always the worry, is that are they going to have a seizure, a withdrawal seizure? Mm-hmm. And then the next step in that, and we'll talk more about when to be worried about DTs or delirium tremens. That's always been our concern from a nursing perspective. And so I just wanted to put a little bit of information in there about why that happens. We know that alcohol is a CNS depressant. People sometimes act crazy and almost like it's not, but long term it's going to depress the central nervous system, mm-hmm. and then that's what causes whenever that alcohol is removed and we don't have it anymore, then we get that into that excitatory state.
Right.
So,
even people that aren't nurses are worried about it. For example, I had a patient last night whose husband, brought her in. She was intoxicated, and he was very concerned about her drinking. But he asked her how she gets the alcohol, because he said she can't really walk. And he buys it for her because he's scared of her going into withdrawal and dying, is what he said. So, yeah. So even non-medical people know a lot about this.
Sure.
Withdrawal and what it can lead to.
And the codependent coping mechanisms that he knows it's a problem, but he participates almost in her problem.
Exactly.
Yeah, because he's afraid.
Because he's afraid of what the withdrawal will do to her.
Right. So, yeah, I love that, you were planning to come in and do this, and then last night you have this patient that is, you're like, okay, this is what we're going to be talking about tomorrow, right? Okay, so he was afraid of her going into withdrawal, so let's talk a little bit about withdrawal and what we can do as emergency department nurses to assess those patients for withdrawal.
So the CIWA, or the Clinical Institute Withdrawal Assessment, Alcohol Revised, it is a tool that quantifies the severity of the alcohol withdrawal, and it is intended to help us guide our clinical treatment of these patients. So it helps us promptly recognize withdrawal symptoms, select our pharmacological treatment, and then administer the pharmacological agent based upon our assessment and mitigate harm or escalate the care if it's necessary.
Right. So really our whole goal with this is to kind of make sure that our patients don't go into withdrawal. So your patient's husband was right. If she stopped drinking, she probably would go into withdrawal, and then this cascade of symptoms, which we're going to talk about a little bit more, would happen. Exactly. And so, I'm sure you probably told him, well, we're in the ER, and there are things that we can do to help her to not go into withdrawal.
Right.
And ultimately, he's afraid that she's going to die.
Yes.
Yeah. Okay. So this slide is a little bit hard to read, but I just wanted you guys to, if you're listening in your car, or you're watching on your computer, just we'll review the actual topics or aspects that we assess. But this is just like a scaled down version of what the CIWA AR looks at. It really assesses for, does the patient have nausea and vomiting? Do they have anxiety? Do they have paroxysmal sweats? Do they have a tactile disturbance, visual disturbance, tremors, agitation, orientation or sensorium? Are they having auditory disturbances? And we'll talk a little bit more about that in a few slides. And do they have a headache? And then the scale is actually scored. Each block on the CIWA AR is scored from either a 0 or a 7. So whatever your nursing assessment is, you'll go ahead and check that box, and then the tool is built into Epic to automatically calculate it for you, so you don't have to keep track of that. It's going to do an automatic calculation. And so if your patient has a score of 8 to 10, that's considered a mild withdrawal. A score of 11 to 15 is considered moderate withdrawal, and over 15 is a patient that is in severe withdrawal. So, Kim, let's talk a little bit about when to worry about withdrawal.
So, stopping or reducing the alcohol use that has been heavy as an alcoholic, it can cause the following symptoms they can start within 6 hours of just stopping this drinking that they've been doing so heavily.
When Kim and I first started talking about this, we both were like, I don't know, it's been a long time since I really looked at alcohol use withdrawal or disorder and when withdrawal will happen. And I kind of was like, oh my gosh, 6 to 8 hours is really not that long before patients start to have symptoms. And I don't know, I was thinking, I wonder if all of us know that if we have that patient who maybe is a hold, right? Mm-hmm. Right now, the EDs are like crazy busy, and we may have a patient who drinks and we don't know that they drink, or they don't disclose that they drink, and they're hanging out in the EDs for 24 hours, and they could really start having some withdrawal pretty quickly in their ED visit. So
definitely. Yeah. I mean, we had a coworker, this was a couple of years ago, but a coworker of mine had a patient that he kind of it wasn't a hold, but he kind of was here for psych. He kind of let him sleep it off. Well, he slept it off. He slept it off a little too much. He couldn't walk. He had tremors, and we ended up having to admit him when he was discharged, and probably would have went and got some more alcohol when he left. But,
so. And taking care of his withdrawal symptoms.
And we probably slept overnight for maybe 4 hours. And
Yeah. But who knows how,
DTs,
how much he drinks.
Right.
Yeah.
The symptoms that you can see starting around 6 hours are some autonomic hyperactivity. See increased hand tremors. They hold their hand down and it just shakes. Insomnia. These patients aren't sleeping well at all. Nausea, vomiting. They have the hallucinations, whether they're visual, auditory. They're feeling bugs crawling on them. The psychomotor agitation, anxiety, and seizures is the end there of the hyperactivity there.
Okay. So if we start seeing those types of symptoms in our patients who are in the emergency department, then that should give us a little bit of a clue that perhaps they do have, some alcohol use disorder.
And I think that some people are under the impression that there has to be pretty much no alcohol in their system. When these patients, they get down, they usually live probably at like 400 or something, and they get down to 150 and they're starting to withdraw.
Right. So we kind of talked a little bit about when the symptoms may begin to start, when we might see them in the emergency department. So it really is pretty quick, 6 to 8 hours after cessation or reduction in the alcohol intake. And that's kind of what Kim was alluding to, that, it doesn't have to mean that their alcohol level is zero. If it's someone who really does consume alcohol all day long, it won't take a zero blood alcohol level to have them start to begin to have withdrawal symptoms. And then probably we may not have them in the emergency department at 72 hours, but that's when the delirium tremens peak. So the risk for DTs peak. But what if we had a patient who is trying to get themselves off of alcohol at home, and then maybe they have a seizure? That's when their family brings them in.
Right.
We would kind of need to assess that to find out, oh my gosh, has this patient not been drinking their normal amount of alcohol for, 2 or 3 days? Then we could get them in that point. And I've actually had patients like that come in where they tried to, I know I'm drinking too much, and I was, my wife's after me, and I'm trying to, get off of alcohol, and, then he has a seizure, and then they call 911, and then here we go. So yes. we've got this problem. So, and then the symptoms actually will start to diminish by 5 to 7 days of abstinence from alcohol. So, and then the other thing that I thought was interesting, we were doing this, little bit of research to put this presentation together, is that if you have patients who are on beta blockers, right, those are the lulls, and the alpha-2 agonists, those are the clonidine and methyl-dopa, they may not have a normal vital sign response, right? So we're looking for some tachycardia maybe that you would see in these patients, but just remember that if you almost have to look at their medication history, because you may not see that, right. Because that can dampen their normal response. So we're going to dig into a little bit more of the timing of the alcohol withdrawal symptoms, so that you guys kind of know when to expect certain symptoms to develop.
So like we said, about 6 to 8 hours, the initial symptoms usually begin. They're tacky, they're hypertensive, they get a fever, vomiting, you see some tremors. They're sweating, they're feeling, anxious, they have the headache, the palpitations. So that's about 6 to 8 hours, and minor to moderate symptoms of the withdrawal are starting. And then in about 12 to 24 hours after their last drink, they may start having some hallucinations. The most common are the tactile, like I said, they feel the bugs crawling on them. That's probably a lot of the biggest complaints. Visual, not as likely. The auditory, may be persecutory. 7 to 8% of patients will have these. So,
which, I don't know, maybe they're telling them to harm themselves or something like that, and then you've got a psych problem and an alcohol withdrawal problem, right? So, which I think we see pretty frequently.
Mm-hmm.
Yeah.
Yep. And then in psych, that's another thing to remember, is psych generally won't assess a patient until their ethanol is less than, I think that got to be less than 100.
Okay.
So,
and so then we know from reviewing all of this is that, oh my gosh, okay, so now we've got their alcohol level down so that psych will assess them, and now they're at higher risk for their alcohol withdrawal symptoms. Yeah.
So then about 12 to 48 hours after their last drink is when you can see the seizures. Usually a short duration, tonic-clonic seizures, a short post-ictal period, not like a normal seizure you would see in a normal seizure patient, but and then 3 days after the withdrawal symptoms, you can have the delirium tremens. They can last up to 8 days. It's a rapid onset, kind of fluctuating disturbances of attention, cognition. These are the patients that are really out of it.
Yeah. Okay. So let's talk a little bit about who's at most risk for going into DTs, because, obviously we don't want them to have seizures and then go into DTs. But there are some clues that can help us to know which of our patients may be at most risk for that. And those include patients who have a history of DTs. So if they come in and they tell you, I've had DTs in the past, then that should give us a little bit of an alert that, oh, I should probably be watchful for that. Yes. If they've had recent withdrawal seizures, that's not a good sign. And if their CWA, if they come in with an opening CWA above 15, and like a history of sustained drinking, that kind of, I thought that was interesting. That's why we're talking about this, because obviously they have a history of sustained drinking. If their blood pressure is really high, greater than 150, and their pulse is over 100, but then just remember if they also are on, a beta blocker, or
the alpha.
Yeah, they went out of my brain.
I know.
Yeah.
Alpha 2
agonist. Yes.
Clonidine.
Yeah. Or if they're over the age of 30, if their last alcohol intake has been greater than 2 days, or let's throw in some benzos, and then that just makes our problems even more, right? So if they're also using benzodiazepines or any other depressant, that can also increase our patient's risk for DTs. And then if they have some concurrent medical illness, one of the most common I think that you see with alcohol patients is pneumonia, right?
Yeah.
Do they aspirate a little bit and then they have pneumonia? So you may see other things, but pneumonia is kind of the most common thing that you may see. So we're going to talk a little bit about the TriHealth ED Order Set. And so I'm going to let Kim kind of take it from here, and we will kind of review some of the changes that you'll see. And this is really what precipitated us to do this little review.
Yeah. So this is a new order set you'll be seeing. The biggest takeaway is we want to do routine vital signs. Generally, it'll tell you, it'll give you a score and how often to do it. You want to do a CWA pretty much upon arrival every 2 hours. But the higher their CWA, the more often you're going to do these vitals, sometimes every hour. If the CWA score is greater than 8, you're going to use the medication protocol. And you want to notify the physician if the total of the Ativan or lorazepam is greater than 12 milligrams in 3 hours. They're having hallucinations, or they have a CWA over 25.
Yeah, that's what I was on.
So you're probably used to seeing Librium. There is a national shortage of Librium. As we all know, there's a national shortage of a lot of things recently, and Librium is one of them.
Yes. Yeah.
So we're going to Ativan.
Yes. Yeah. So that was one of the things, we worked pretty closely with Dr. Tenney and Dr. Sheridan to refine this order set and make it ED specific. In the past, some of you may remember that it was like just a TriHealth inpatient order set, and so we felt that there was a need to have one that was just focused on the emergency department, and so that's really what this does. And I can remember back in the day, everybody got Librium, and I was like, well, what the heck? Why are we going to lorazepam or Ativan? And it really is because of the national shortage. And so one of the things that Kim and I, when we were talking about the patient's alcohol level, we kind of did a little digging on the internet to find out that for every 1 hour the patient's blood alcohol content decreases by 0.015% of blood alcohol concentration. So it's interesting because you hear people talk about, oh, the blood alcohol was, like a 0.8 is the legal limit, right? But when we look at that, comparing the way we report a blood alcohol level, like 100 milligrams of serum alcohol is a 0.10% BAC, like the law is looking at, right?
Right.
So a 400 milligram is a 0.4. So think about that. So the legal limit is 0.08.
Right, so you're at 80.
Yeah. So, okay. And you're right, psych won't talk to an inebriated alcoholic patient until their blood alcohol level is less than 100 or at about 10%. So just be watchful. Those are the patients that we might have trouble with.
Exactly.
And then this is just another snapshot of that order set. And it really just follows you through making sure that you do your CWA. The CWA is going to help guide what you do with the order set. And your medications are going to be based upon your CWA AR score. So, and if you're giving lorazepam, to the 2 milligram IV, if the CWA score guides you to that, we just want to make sure that we're using the RAS score to determine sedation level.
Yeah.
And that RAS score is not new. We've been using the RAS score on all kinds of things, and so it's just the same old RAS score. It's just a reminder to make sure that you do it if you're having to give IV Ativan.
Yes, and you don't need an order to do the CWA. Just remember that. You can start the CWA if you feel it's appropriate. It's totally a nursing judgment. Do the CWA and let the doctor know, and they can initiate this order set for us.
Sure. Yeah, absolutely. If it's somebody like you're doing the triage on the patient, and you're going through your triage, and you're like, how much do you drink? And they say, I drink, a 30-pack of beer a day. That seems like, wow, a lot. But I think that there are people who drink that. Or they say they drink,
like a handle or a liter.
Yes,
of
vodka. I feel like vodka is like the thing.
I feel like vodka is
they drink a handle.
Yeah,
a
handle is usually a handle.
And you're like, a handle? What is that? It's it's like, so you
it's the big
pick
liter
it up
bottle
and
with the handle
bottle. And so if they tell you that they drink that much, and like, when was your last drink? And they say, let's say, last night, and it's morning time, I might do the CWA just to see, because if they drink that much, they might start having problems sooner than I think they might.
Exactly, and if it's somebody, and that's when you got to think about when you're triaging their ESI. If they have told you, I haven't been drinking, it's been almost 6 to 8 hours. So you think you would think about elevating that ESI.
Yes. Yeah.
You don't want them sitting in the waiting room.
Yeah, I think that's smart, especially with, right now, all the EDs have been more busy than we had been, like, a year ago when we were in the middle of the COVID pandemic, whatever, we were
when
kind of like
scared
cooling our jets, right? And now everybody's here,
right.
And they're not afraid to come in, and they're sitting in the lobby. So just think about that. That could be that patient, that starts to maybe have a seizure in the lobby if they had really not been drinking through the night.
Right.
So just words of caution, right? And then just some other medications to think about. Phenobarbital is also a drug that whenever we were doing our research on this presentation, that phenobarbital is one of the drugs that is available. The physicians didn't choose to put that in the actual order set, but I know that we have some pretty progressive physicians who, may have read an article or something there. They think that phenobarb may be a better choice. It does have a dual action, and it kind of goes back to that pathophys that we were talking about earlier, where it increases the duration of the GABA receptors opening, and it inhibits the glutamate receptor activity, so it may have a little bit of an effect on somebody. So just, it's out there. they could order it and
Yeah,
you can
you
get
see
it.
it.
It's not a problem. So both oppose the alcohol withdrawal effects. The thing about the phenobarb is it has an onset of action of 5 minutes, so pretty fast. It peaks in 30 minutes, and then it has a half-life of 3 to 4 days, so it kind of like lasts a little bit longer than lorazepam or the Ativan. Right. And that is it. So what will happen, you guys, is whenever you get this, you'll have a quiz that you'll take, and then this offering is good for 0.5 CE, so you will get continuing education for this session. So thanks for your attention. We appreciate it. And now I hope you feel better taking care of those alcohol withdrawal patients.